Good afternoon. We're going to cover a perfect code in under 5 minutes, so buckle up. A lot of this perspective is going to be based on pre-hospital because when you have codes, primarily pre-hospital setting, EMS is the first to make contact, and as you look, the numbers are pretty dismal for both adult and pediatrics. Sudden cardiac arrest, loss of heart function, kills 450 Americans a day. Number one cause of death, mortality is about 90%, and the number has not improved over 60 years, despite doing ACLS. Resuscitation changed in 2010 when they looked at switching from ABC to compressions, airway, and breathing. And they found that airway control is a much lower priority for cardiac arrest patients, and the mantra they came up with is push hard, push fast, save lives. Circulation in 2012, what's the optimal compression rate for cardiac arrest? For optimal resuscitation rates, study showed the optimal rate was 120 per minute, and once you've achieved this, the number of resuscitations would significantly improve. What's your optimal depth? For adults, it's 2 to 2.4 inches, or a third of the chest diameter. For infants, 1 month to 1 year, it's 1.5 inches, and 2 inches for children between 1 and 18 years of age. CPR fraction, this is the time you spend on a chest. So during a cardiac arrest, the optimal numbers are between 80 to 90%. If you can maintain this kind of time on the chest, the results are significantly higher. Realize that the coronary perfusion pressure needs to be at least 15 millimeters to retain ROSC and sustained rhythm. Interrupting chest compressions, this is a big no-no. Every 1 second pause results in a 1% loss of chance of ROSC. It takes 10 compressions to begin to fulfill the coronary artery pressure to 15. It takes 30 seconds to start perfusing the brain. So during resuscitation, minimize times off the chest. CPR interruptions during shock. So perishock pauses are pauses you time to check pulses and assess the patient. Optimal pulse time should be under 10 seconds. Pause times less than 20 seconds have improved survival to discharge rates. Any shock checks over 20 seconds have been shown to decrease survival in cardiac arrest. And realize pulse checks are only accurate about 15% of the time during a code. So when should out-of-hospital cardiac arrest be stopped? 74% of patients in the study in circulation obtained ROSC within 9.3 minutes, 90% survival to discharge if ROSC was obtained within 15 minutes. 2% of all resuscitations did occur after 15 minutes of CPR. So there are actually survivors who can be attained after 20 minutes. And after 20 minutes, basically 15 minutes or more, non-ACLS recommendations are considered, and realize in this study the compression factors, which were between 48 and 66%, which is significantly lower than what you would optimally like to have. Now, we all feel we can do chest compressions endlessly. However, resuscitation in 2013 showed that there was a 7% decline in depth of compressions at 2 minutes, 14% decline at 3 minutes. So if you can, if possible, try and switch every 2 minutes with when you do resuscitations and chest compressions. A big tool we use in the pre-hospital setting, and hopefully we're using it more in the hospital setting now, is Untitled CO2. Untitled CO2 is a measure of cellular production and transport of carbon dioxide in the body. It measures metabolic rate, ventilatory rate, and blood flow and circulation. It's also synonymous with cardiac output. So as you do CPR, as your quality of compressions are good, your end-tidal CO2 will improve, and it gives instant analysis of cellular metabolism. And a summary of 3 articles showed that a drop of end-tidal CO2 with CPR is associated with respiratory fatigue and also worsening of arrest. So it's time to reassess. End-tidal CO2 increases by 13.5 millimeters when obtaining ROSC, so look for jumps in end-tidal CO2. And survival rates were increased 16% for every 1 millimeter increase in end-tidal CO2 in a resuscitation. When to stop? If your end-tidal CO2 is greater than 10, continue CPR. If your end-tidal CO2 is less than 10 for 20 minutes, it's pretty much assumptive of clinical death, or specifically in PEA, but for asystole and PEA as well. Airway management and codes. We spent a lot of time trying to intubate initially. Oh. Okay. For VFib, there's witness unwitness VFib. For witness VFib, you're going to be doing an immediate defibrillation, and if it's non-witness, you would do compressions before defibrillation. So,
thank you.
Thanks.
Appreciate that. Great. Round of applause.